Good evening, everyone. This is Meldita and I'm back. So here at my YouTube channel, Meldita's Info Corner, and I have also my Facebook, John Rigacho at yahoo.ca. Okay. Defibrillation or asynchronized cardioversion. Okay. So this is my last video or my third video about management of pulseless ventricular tachycardia. When we speak of defibrillation, this is the application of electrical shock to the heart muscle right away. Okay. So we have cardiac arrest, abnormal rhythms, and that need defibrillation. Number one, we have ventricular tachycardia that could either be monomorphic or polymorphic. We have also ventricular fibrillation that could be fine or coarse. Okay, and the first defibrillation requires 200 joules. The second defibrillation requires 300 joules. And the third defibrillation requires 360 joules. There are two types of defibrillation. Okay, so we have the one by the monophasic defibrillation or defibrillators. And there's also the biphasic. But nowadays, we are using now biphasic defibrillators. But anyway, we'll just have to see the difference between these two. So monophasic defibrillation means the flow of electrical shock to the heart muscle is one direction. So we have only one direction here, if you see this. So that's only one direction. Okay, right here. That's only one direction. Okay, I will show you closer. So there is a one direction in here. If you use the biphasic defibrillation, it goes, the electrical shock goes, or the flow of electricity goes in two directions. The flow is coming from here, lower pad to the higher pad. You see the arrow? And there are some electricity that travels from here down to the other pad. And it has more coverage of the heart muscle, okay? But nowadays, most of our machines now come as biphasic defibrillators. Okay, most of the machines. Okay, so you are in CCU. Suddenly on the central monitor, you see that your patient with atrial fibrillation went into wide complex tachycardia. So I give you two examples in here. So what the CCU RN will do, will rush to the patient's side and notice that the patient is not breathing and has no pulse. Will hit the code blue button on the wall and then start her CPR. I have another one here. A patient has univentricular pacemaker, ventricularly pacing, then suddenly went into wide complex tachycardia. The CCURN rushes to the patient's side and the patient is not breathing and the patient has no pulse. Hit the code blue button and start her CPR. So the RN will go and grab the crash cart with the defibrillator and arrives at the patient's side. So we're gonna do the first defibrillation attempt here. So the first responders actually are the CCU RNs, and we will be dealing with our first defibrillation, which is 200 joules. So what will the RN do? So the defibrillator RN will press the power button on, okay? So we will press this power button on here. Okay, there we go. That one, she will press that. Okay, we will press the power button. And then the other RN will apply the pads anteriorly and laterally. So this is the anterior lateral approach of the defib pads. The defibrillator RN will press energy select. Usually, our defibrillator machine is already preset at 200 joules. So the defib RN will press this, okay? And then next, she will press the charge. So you can hear the escalating sound of the joules from the lowest to the highest until it hits 200. Okay, it stopped there. And then the defib RN will say all clear loud. So the CPR RN will stop her CPR briefly. And then the defib RN will press the shock button. Okay, This is the shock button. Okay, now, usually with quick management, we succeed with our first defibrillation. That's very good. Now you question me and say, what happens if the patient remains in ventricular tachycardia? So we're gonna do our second defibrillation attempt. This time we're gonna be using 300 joules. Our responders are CCU Code Blue team. We have some CCUs, they have their Code Blue team. That is the RT and the cardiologist will arrive, or the hospital Code Blue team. So the whole crew will arrive. So CPR continues by the RN when BTAC remains. The RT will do the back mask ventilation, and the cardiologist or the doctor of the hospital team might consider giving magnesium or amiodarone. So the defibrillator RN will get ready with her defibrillation second attempt, and the CPR has to be the CPR will be in 2 minutes. So what you're gonna do while waiting to shock the patient, she could either have that 300 joules ready and have already the charge done. All she has to do, if the nurse is finished with her CPR after 2 minutes, she can go ahead and press the shock button. Okay, that's it. And all she has to do, press. She had pressed the energy, it's already 300 joules, right? She had already pressed the charge. She will say all clear. So the RT, the CPR RN, everyone has to be off the patients so that they don't get the shock. So everybody has to be off the patient. And then the defib RN will press the shock button. Okay, now you're gonna ask me again, what if the patient will still have the ventricular tachycardia? Okay, usually if the patient is in CCU, they come in heart failure. So one of our medications that we give is diuretic, and we lose some potassium, some magnesium. So they could be hypokalemic or hypomagnesiemic. Okay, so they have low magnesium or low potassium. Okay, or they could develop a new thrombosis. They have probably some blockages in the coronary arteries, or even after stented, they might have blocked the stent. So that is cardiac thrombosis. So these are the very common causes in the CCU. But there are other H and T's causes, but it's not really not noted mainly in the CCU. As I said, it's mainly the low potassium and low magnesium, and it could be cardiac thrombosis, okay? Pre or after stent, or it could be a non-STEMI ended up into a STEMI. Okay, so it's not always the H and the T's here. Just so you know that in CCU, we are also dealing BTAC caused by some electrical abnormalities. We have patients with long QTs, these are genetics, channelopathies, Brugadas, fibrosis, cardiomyopathies. They can all have, BTAC, but they could be aggravated, or that could escalate if they have more other factors involved, like low potassium or low magnesium, or ischemia or anything like that. Okay, so when our defibrillation succeeds, this is what's gonna happen. So we see that originally they are in atrial fibrillation. Okay, they developed wide complex tachycardia. So here on the defib monitor, we apply the shock, and what you see here